So our lecture tonight, unfortunately, I am unable to make it to class, so I thought I'd video it without me in it, and you can just hear my voice. So hopefully this is going to be fine. Again, sorry guys that I had to skip this lecture again, but hopefully this will help you out a little bit to understand things. Okay, so we're going to be talking about elbow injuries tonight and conditions that go along with elbow injuries. So our first one is olecranon bursitis. So if you can recall, a bursa is a fluid-filled sac, and they're found in many parts of the body. And this in particular one is found, if you can see this red portion right here, it's found between the olecranon process, which is part of your ulna, and the skin, the outer surface here. So mostly the bursa becomes disrupted or inflamed when you fall on that point of the elbow, so directly onto the elbow. And some signs that you might have a bursitis is you get a lot of swelling in that area, and can be like up to the size of an egg, or even larger. I've seen some that are even bigger than that. You might get some heat and some redness. I had a player this year, basketball player. He was taking the ball away from someone or guarding the ball, and he came back with his elbow and got somebody in the mouth, and the teeth went into his elbow. We contemplated whether or not to stitch it up so that he can probably get back to play earlier, or to leave it open. Lots of times you leave it open because you don't want any infection to take place. And anyway, it got stitched up, and it did get infected. And you can think about, if you think about it, it's just like, sure, it was his, tooth just dug into his elbow, but it was actually like a bite. So there's high risk of infection, and that is what you want to be careful with a bursa. You want to be able to tell if it's due, if it's just a simple traumatic bursitis, or if it is an infected bursa. So some treatment, you want to be able to put a protective pad over the bursitis area. So in this case, the elbow. So you would probably do a donut, so padding that has a hole in the center, and then you can function okay, and it's going to protect the area. You also want to ice the area. You can do an aspiration, and, well, not you yourself, but somebody would do the aspiration. And again, you want to be careful of that because there is a higher risk of getting an infection when you aspirate something like this. Number 4, surgical excision. And number 5, you obviously want to be on antibiotics if there indeed is an infection. So I'm just going to show you a little video. It's gross, but it is the aspiration part. So you can see here, he's going to dig it in. It's really jello-y like, and out comes the fluid around it. Now that's not the bursa coming out. That is the fluid around the bursa. And that's pretty much it. All right. This one shows no infection. There's quite a bit of swelling here. If you look on this elbow, it's pretty good, and this one has pretty profuse swelling. This one is our infection. So looks pretty nasty, red, swollen, definitely infection in that bursa, in that elbow. Elbow dislocation is our next condition. So most common dislocation is the radius and the ulna. They get displaced posteriorly. So you can kind of see here is your radius and your ulna, and here's your humerus. So they get displaced backwards or posteriorly. So the dislocation in an elbow usually, as well as other joints, usually ends with the rupture of all the stabilizing ligaments as well. And with a dislocation, you often get a fracture of the radial head. And here's a picture, better here, you can kind of see, here's your humerus, and here you can see the radius and the ulna going posteriorly backwards, and here is the head of the radius right here. So sometimes you get a fracture in this part of the radius. All right, so you can have a dislocation happen when you fall on an outstretched arm, and the arm is usually in hyperextension when you fall on it, so it's extended to its maximum. You can also get it with a severe twist while the elbow is in flexion, so totally flexed, and you get a severe twist. So you're going to get some deformity, as you can see here in this picture. There's quite a bit of deformity here. And you can really tell that it's pushed back posteriorly. You get a huge amount of hemorrhage and swelling, severe pain, and a lot of disability. So important when you get any dislocation, obviously, is to check your pulses and innervations. You want to make sure that no blood flow is impeded, and nothing neural is happening. You want to immobilize for 3 weeks in flexion if you have an elbow dislocation. You want to pier or rice, whichever one you want to call it, with a sling, and that will immobilize it for the 3 weeks. You're not necessarily in a cast, but you are immobilized in a sling. You want to refer to a doctor for reduction ASAP, and again, it can be an EMS or an emergency. And treatment-wise, you're going to go through rehab, introducing a lot of hand, forearm, shoulder exercises. So I won't go into the YouTube video here. It is a reduction video of the elbow. You can have a look at that yourselves. Little tidbit here is my children's names are Finley and Tate. So next one is osteochondritis dissecans. So I'm not sure if you remember that from the knee, but osteochondritis dissecans is when you get loose bodies in the joint, and they're comprised of the articular cartilage and the bone. So if you can see here in this picture, a little piece of the bone pops off here, and again over here. So the articular cartilage and the bone can break off, get a little bone fragment. So this causes a loose body within the joint, and it's called, you can have joint mice, and that might get caught in the joint itself. So a big way you can get osteochondritis dissecans is in young athletes during throwing. They get compressive and tensile forces during throwing. So here are your compression forces, your tensile forces coming this way. And if you can see these dotted lines, and inside are the blue, but outside here, the white dotted lines, this shows the epiphysis. So that's the growth plates in young kids. And so what happens is part of these can break off, and you get your little joint mice, and again, osteochondritis dissecans. So with repetitive microtrauma, by way of rotation, extension, and valgus stresses, this leads to compression of the radial head and the shearing of the radial humeral joint. So in here, the radial humor joint. Most common in athletes 10 to 15 years old, and again in throwing or racket sports. And when they're younger than 10 years old, it's called Panner's disease. And I'll have that maybe as a question in your readings and assignment. So signs, you're going to get sudden pain with this. You're going to get locking, again, mostly because the loose part of the bone gets caught in the joint itself, and it locks, and you can't get full extension. So you get decrease of range of motion. You get swelling. You get crepitus. Crepitus is that grindy, creepy or creaky type feel. You get tenderness over the RH joints, or the radial humeral joint, and you get a grating sensation with pronation and supination. So treatment, you want to get x-rays for sure with this. It's a bit of a fracture, right? You want to restrict activity activity, you might be put on anti-inflammatories, something like that. You may splint it or cast it, and sometimes you also have to have surgery to remove the loose bodies. And again, you want to exercise the pier or rice for shore in this case. So on to the next one, medial epicondylitis. So medial epicondylitis, I know it's a big mouthful or whatever, but really it is somewhat an inflammation of your origin at the wrist flexors or the wrist extensors. So it's also known as pitcher's elbow or racquetball elbow, javelin thrower's elbow. And again, you get it when you have a repetitive microtrauma to the origin of the wrist flexor muscles. So right here, the medial epicondyle is right here, and your wrist flexors come off of the medial epicondyle. So they run down here along your forearm, obviously into your hand. So it is what makes the action of flexion in your wrist. So repeated forceful wrist flexion, such as something like you would do in golf. Lateral epicondylitis, that's on the outside. So it's also known as tennis elbow. So again, repetitive microtrauma to the origin right here of the wrist extensor muscles. So commonly the tendon unit of the extensor carpi radialis brevis. Again, with this one, it's repeated forceful wrist extension because, again, your forearms that extend here run down and allow you to do your wrist extension. So medial lateral epicondylitis, your signs and symptoms of this. You're going to get pain at the injury site. You're going to get pain right at the two epicondyles, so either the lateral one or the medial one. The pain may radiate down the forearm, again, because that's where the attachment is for all your forearm muscles and the tendons. There's going to be point tenderness right at that epicondyle. There's going to be mild swelling. There is probably sometimes going to be a decreased range of motion, mostly due to the swelling, but you will get a decreased range of motion. Passive movements are okay. So if you remember, passive movements are those that are done with you relaxing and the therapist doing the movement for you. And again, those are okay, but it's the active and the resisted movements that are quite painful. So a test for this, it's elbow flexion at 45 degrees, like here in this picture. The lateral tendons, you want to test resisting wrist extension. So this is showing wrist extension going up that way, this way. And then the medial tendons, you want to turn your hand up the other way, and you can resist wrist flexion. So a positive test would be that you have pain with this type of resistance. So because it's an epicondylitis, so anything with itis usually refers to some type of tendinopathy or tendonitis. So stage 1, you get an acute inflammation. You don't have any angioblastic invasion, which means like your disarrangement of collagen being replaced by normal tendinous material. There's none of that happening. You get pain during activity, and you get a minor ache usually after the activity as well. Stage 2, you get a chronic inflammation, and you get more scarring happening at the epicondyles. Pain during the activity and at rest with stage 2. Stage 3, you get a good scarring and a calcification occurring. There, may be micro ruptures of the tendon. Sometimes there's partial rupture of the tendon. There's pain at rest, and now you're getting pain sometimes at night as well. And it hurts during numerous activities during daily living. So it's progressed in stage 3. So some treatment. Obviously we want to do rice or peer. We're going to do some ultrasound or IFC in the clinic. People can take NSAIDs for sure. A brace that goes on around the area of the epicondyle, so it dissipates the stress from the common flexor or the common extensor tendon at the epicondyle. So it decreases the concentration of direct force on the bony muscle attachment. So you put in the lab, I'll show you how you can kind of make your own pad or brace for that, and it's kind of similar to the patellar tendon one. And in extreme cases, surgery is going to take place. So there is some prevention that we can do for medial and lateral epicondylitis, and it's more of a common sense type thing. With so for example, with tennis elbow, you want to adjust the racket size. So you want to use a mid-size racket if you need to use a mid-size racket. The popular oversized rackets can put too much strain on the arm and increase the risk of injury. You want to loosen the string tension. So too much string tension can increase the torque and the vibration in the arm, increasing risk of injury. Again, adjust the grip size and check racket material. Okay, so on to a few other elbow injuries. So the UCL sprain, so the ulnar collateral ligament. It results from strain, obviously, to this ligament that I just said, and it's common in baseball pitchers. Anyone who has a complete tear of this ligament, there's a surgery, and it's called Tommy John surgery. So it's named after Thomas Edward John Jr. He played for the LA Dodgers, and he was the first one to successfully undergo this type of ligament replacement in 1974. That was the year that I was born. Okay, so if you think about the ulnar collateral ligament, it's kind of like it can be called MCL, and it's kind of like the MCL, which is the inside ligament on your knee. So usually for this surgery, they harvest the palmaris longus. So in this picture you can see, if you take your thumb and your pinky finger and try to touch them, and give a little tiny bit of pronation, the palmaris longus will pop out, and you can see it there in the picture. So they usually harvest this tendon to replace the torn UCL ligament. But only 85% of people have palmaris longus tendon and 15 don't. So lots of times they can't use that if you don't have it. So you can use plantaris or semitendinosus, which semitendinosus is a hamstring tendon, if this one is not available. So next we have cubital tunnel syndrome. So if you bend your elbow, say at 90 degrees, and on the inside there is, your epicondyle, so it's that bone that protrudes there. So if you just go just underneath it, in between those, there's a little, I'll call it a tunnel because that's exactly what it is, but you can place your finger right in there, and that is where your cubital tunnel is. An exposed position of the medial humeral condyle can lead to a variety of problems. So it is an exposed area. So 4 factors that can lead to this tunnel syndrome. One is an injury from a valgus force. Another is irregularities within the tunnel. Third is a subluxation of the ulnar nerve from lax ligaments. So the ulnar nerve doesn't stay in that little tunnel. And then the other one is compression of ligament on the nerve. So you're going to get pain on the medial aspect of the elbow for sure. You're going to get tenderness in that cubital tunnel, but you're also going to get tingling in the 4th and 5th fingers. So you can see here, you're going to get area of pain and area of numbness right in here. And Tinel's test is how you would kind of decipher if it was cubital tunnel syndrome. Management for this: rest and immobilization for around 2 weeks, give or take. Again, you can be put on NSAIDs. You're going to do some treatment in the clinic for it. You might need to have some splinting put onto the area, and sometimes you might need a surgical decompression if all else fails. Okay, we're on to fractures. So fractures in the elbow. So most often, again, you're going to get a fracture most often from falling on an outstretched arm. and there's obviously three bones in the elbow that can get broken. Most elbow injuries are caused by one of two things. And again, I just said falling on an outstretched arm, and the other one is throwing. Baseball pitchers can fracture their elbow from the force of a pitch. I won't go into the YouTube video here, but I want you to watch it. I think if I go into it, you're not going to get to see it very well. But it is quite interesting to see what happens to a pitcher on occasion when a fracture happens. So yeah, please watch it, and it's quite interesting. So your carrying angle, something you want to look at. It's a distal extension. You have a distal extension of the humerus on the medial side, so the inside, and your carrying angle, it should measure a certain degree. So 10 to 15 degrees in females and 5 degrees in males. An increased angle equals a cubitus valgus, which is very common. A decreased angle is a cubitus varus, which is very, very rare and can lead to injury. Volkmann's contracture. So when you get a disruption of the brachial artery, blood flow to the forearm and the wrist and hand is interrupted. So you get a complication of major elbow injuries when you get a contracture. So you might have a fracture, you might have a dislocation, you might have something going on in the forearm, maybe some immense swelling, and it causes a contracture like so here in the hand. And very, very important that this gets looked at. People, you can't get out of this position. A contracture means that it's stuck in that position and it can't get out of that position for some reason. So signs you want to look for are pain in the forearm, increases when the fingers are passively extended. So if somebody took them and tried to passively extend them, the pain is going to be way, way, way more. The pulses, the brachial and the radial pulses are non-existent or very, very weak. Coldness distal to the elbow, and a decreased range of motion happens when you have Volkmann's contracture. So you want to treat this. You want to do whatever needs to be done to remove the external pressure, and obviously that's in the tensors itself. Elevation to prevent excessive swelling, and you need to get them to the hospital ASAP so no more complications take place. And if you don't get them looked at right away, a complication of the contracture, it can be permanent, and necrosis takes place after 4 to 6 hours, which is the death of the cells, right? And that is it. So if you have watched this, you will know that you need to look up, what am I going to get you to look up? You're going to look up Tinel's sign and what is Tinel's sign. I'm not going to put that in the questions. You're just going to know because you watched this that you need to tell me in your answers for your assignment that what Tinel's sign is, what you do for that test. And I will know that you watched this unless you got it from someone else. But hopefully not. Okay, sorry again, and hopefully you sat through this and learned something. All right, I'll see you guys next week.